All right, so hello. We are at Coplow rounds this morning. We're going to talk about some eyeballs. We're sharing the screen. Okay, so we're going to keep going. So my name is Megan Kleinmans. I'm one of the staff pathologists at Coplow, and I'll start us off with two cases today. So without further ado, let's get into it. So the first case today is a 12-year-old neutered male domestic short-hair cat. This cat had a 2-month history of gradual hyperpigmentation. I assume of the iris is what they're referring to, and a large pigmented mass found in the dorsal ciliary body extending into the anterior dorsal iris. They'd say 2+ flare, or cell flare specifically, and a secondary glaucoma. We have some other things, diabetes and high blood pressure and things like that, but the main stuff is the mass. So we have this globe, which is hemisected. We've got our cornea up here. And mostly what we have is this large mass in the ciliary body. So the iris leaflet is roughly here, which means this mass is in ciliary body and in choroid. Our optic nerve head is back here. We do have a little bit of brown pigmentation and thickening even in the iris sort of opposite to where the main mass is. So there's a little bit more of a generalized pigmentary thing going on as well, but mainly this large mass in ciliary body and choroid. Right, let's switch to the histology. Start by attempting a subgross, and you'll see our shame of some of the tumor is dropped out. So don't mind that though. We have great diagnostic results here still to look at and a lot to learn. So we have our iris leaflet here. We have our optic nerve head here. And again, that large pigmented mass, some of which is kind of gone artifactually in our ciliary body and choroid. And again, if we walk over to the opposite iris leaflet, we have a little bit of a pigmented population up there as well. So it's somewhat of a more generalized distribution, but mainly there's a large mass effect. Let me get rid of the fuzzies. And here we are. So now we've rotated so that our cornea is on our left. And we're going to start by dropping in on the bulk of this mass here. Oh, wait, sorry. This is our gonio slice. Our cornea is over here. There we go. All right. Now we're oriented. Our cornea is on our right. And we're going to drop in on our main mass here first. And mostly what we have is solid regions of these kind of rounded polygonal cells. Many of them are fairly heavily pigmented with obscured nuclear features, but quite a few of them have eosinophilic to sometimes lightly pigmented cytoplasm, a nucleus with a pretty distinct nucleolus and clumped chromatin, maybe 2 nucleoli sometimes. So this is a fairly pleomorphic population of cells. Ultimately, now I can't remember what I got for my taught account. We're interested. I got 10 and 10 high magnification fields. So this kind of ultimately looks like feline diffuse iris melanoma tends to look. We can take a quick peek at the cells over here in the adjacent iris, which look kind of much the same. So because the cell morphology in this case is reasonably what we tend to see with feline diffuse iris melanoma, that's one thing to note in this case, but the distribution of the cells in this case is atypical. Most commonly with feline diffuse iris melanoma, what we see is a progression from carpeting the anterior iris surface and infiltrating the iris stroma, then involvement of ciliary body, and then potential progression to involve adjacent structures like sclera and choroid. In this case, there is a more generalized involvement of some parts of the anterior uvea, but the bulk of the tumor essentially is in the ciliary body and choroid and making a sort of distinct mass effect, which is not common for melanocytic neoplasia in cats in general. Most commonly it's phytum, and most commonly it's in the anterior uvea. So what I think we're kind of pushing to call this in Coplow would be phytum with an atypical location, essentially. And as far as we know, these atypically distributed feline diffuse iris melanomas or these atypically distributed melanocytic neoplasms in cats don't necessarily behave any differently from what we expect for feline diffuse iris melanoma otherwise. So, however, while we're on the topic of atypical melanocytic neoplasia in cats, the typical being feline diffuse iris melanoma, like we just described, the other one that is worth mentioning, and with a representative histologic photo here of a different case, is what we would refer to as feline atypical melanoma. So these tumors tend to be very heavily pigmented. They're pretty commonly in the ciliary body and or choroid, as in this case, this one was. So like the gross view of these cases can be very similar to our case that we just looked at. But they tend to be pretty bland cytologically. So cytomorphology tends to be kind of bland. They tend to be very heavily pigmented. It's kind of reminiscent of what you would expect out of a melanocytoma in a dog, but this isn't a dog, this is a cat. Mitotic count can also be quite low. However, there's evidence to suggest that despite how bland these can sometimes look, they may still have metastatic potential. So I think the main thing to think about in cats is that we probably have evidence to suggest, worrying about metastatic potential, even if it looks kind of bland and weird like this. Ultimately, I think we probably still have some work to do in terms of melanocytic neoplasia in cats in general. FITM still could use some work too. And just a quick plug to if you have a way of diplomatically and gently encouraging clients to do necropsies on their cats that have been diagnosed with melanocytic neoplasia. If you're in clinical work, that would be cool. We probably need more data, postmortem data in terms of metastatic potential for these lesions. But basically just an overview of the somewhat atypical melanocytic neoplasms of cats in the uvea. Any questions or comments? Okay.
What was the process on the other side?
Same thing. The tumor was just more extensive than like it appeared essentially initially. Still just kind of atypical in terms of distribution to have like a mass effect in the ciliary body and choroid for a cat. Okay, cool. This is a representative photo for the next case. We didn't have a gross photo of the specific case that I'm going to show you that we got more recently. This is a 10-year-old mixed breed neutered male dog. And see attached, boogers. All right, so wait a second. Yeah, maybe. I think mostly it's probably just gonna be retrobulbar mass is the history. But 4265. Gillian's got us. Let's see. Yes, so large, firm dorsal subconjunctival mass that seems closely associated with the sclera. It's about a half the size of the globe or slightly larger. There's some corneal lipid, some anterior vitreal prolapse. The globe is pushed down and out of position, which they describe as basically a form of exophthalmos. And a little bit of cataract, some other stuff, but mainly this mass, periocular mass or orbital mass. Thank you, Gillian. So let's take a look at the gross photo first. So we have a relatively normal eye, although it's being maybe squished a bit by this adjacent mass. The mass in our case that we're going to show you histologically was probably a little bit larger than this, but otherwise probably looked pretty similar. You can see that this mass is essentially subconjunctival in this case. Basically, the bulbar conj is bulging forward because of this mass, and kind of episcleral to orbital as well. It's ultimately a fairly well-demarcated mass. You can see that it has distinct borders to it. And this mass probably at gross exam would have been like fairly soft to semi-firm, and this sort of like pale tan appearance. So that is the gross view. And we'll take a look at the histology. So this is now our actual case. That photo was represented before, but it looks pretty similar. You can see we have a bit of an off-center cut of our globe. We don't have the pupil in this plane of section. It's just one solid iris, and the cornea is a bit peripheral. But here's our cornea, our iris, and our lens. We've got our globe over here, and then We have this pretty distinct, well-demarcated mass that's bulging up kind of underneath the conjunctiva. There's a giant fingerprint.
Right.
Oh dear. Now my fingerprint ridges are going to be on YouTube forever.
Uh-oh, Megan.
I know. I hope I don't do anything untoward. I don't know. Anyway. Okay. All right, fingerprint gone. Sorry about that. It's like slowly dawning on me that somebody said something. Anyway, large, well-demarcated mass bulging up underneath the conjunctiva in the episclera and orbital connective tissue. We can see this discrete borders of this mass all the way around. I'm lost. There we are. So let's see, let's orient ourselves first. Here's the optic nerve, our cornea is to the right, and here we are in our mass, and we'll drop down on it. We'll pick a spot and we'll sit there. So these are, this is a solid regions, they're essentially sheets of cells that are kind of rounded polygonal. They have abundant cytoplasm that has this finely vacuolated appearance. So kind of a term that I learned during residency that I love is you have these vacuoles in the cytoplasm that are kind of indistinctly demarcated most typically. And it produces a diaphanous effect in the cytoplasm. Diaphanous, I love that word. Anyway, so it's pretty, I think people might also refer to this as ground glass. You could go with that if you want, maybe.
The literature covers like both the vacuoles themselves are referred to as diaphanous in some references in the cytoplasm.
Okay, cool.
And so instead of being some sort of a thin veil, it's pretty obscure as to what.
No, it's cool though. It's such a cool word. Anyway, you could say ground glass if you wanted to. I like diaphanous. It makes me happy. Anyway, so regardless, these are vacuolated cells, and the cell border or the vacuole borders are essentially indistinct. Although sometimes you'll get these sharply demarcated, punched out vacuoles here and there that look a little bit more classically like what you'd expect for lipid. So this tumor is most likely a tumor of brown fat, and the diagnosis here would be orbital hibernoma. It's also, or maybe alternately possible that this is a tumor that arises from some sort of progenitor cell. It's worth noting that skeletal muscle, white fat, and brown fat have a common progenitor, which is part of the reason why it can be so difficult to distinguish them, including with immunohistochemistry. Technically, orbital hibernomas should label with UPC1 or uncoupling protein 1, which is like kind of thought to be relatively specific, maybe, but it ultimately isn't totally specific to brown fat. Potentially, if you have a fatty tumor in the orbit of a dog, you could have other differentials, and especially in cases that are maybe a little bit more pleomorphic than this. These like nuclei are relatively bland. There's fairly low nuclear pleomorphism. It's easier to make the diagnosis. If there was more pleomorphism, it might be a little bit harder. That said, other types of fatty tumors in the orbits of dogs are a lot less common than this one, for what it's worth. And it helps, of course, when you get the whole eye instead of like an incisional biopsy and get to see that the borders of this are distinct. So we have a pretty sharply demarcated, not particularly invasive mass, sort of an expansile mass. So basically, the overall features in this case consistent with orbital hibernoma. Essentially a tumor of brown fat in the orbit of dogs. I think that's all I have to say about it. Are there any questions or comments? Okay. Hibernoma. And with that, I will shift.
They isoliferous very often anymore, do you?
Would that work there, you think?
Then it would imply a
Technically,
different tumor.
probably, but I think it's been pigeonholed into ordoma.
Somebody said it seemed really subconjunctival. Is that unusual?
No, not unusual at all.
Not unusual at all.
All right. This is Kelsey. I'm going to be doing the next two cases. Our first one, we're going a little bit into the Wayback Machine. This is a 2024 case. I had a more recent case with this entity, but it was a little bit tricky to track down the slide. So this is the same entity, just an older case. So this is the globe from a 3-year-old female spade lab mix. And, you know, I forgot to change the history from my more recent case. So I'm just going to make up a scenario for this one, I imagine. Sure, that should be great.
So is it
Gillian to the rescue again.
13487 or is it different?
13487.
This dog couldn't find its parents, so it went to the Himalayas and was looking at.
Yeah. Actually, that might be it. Yeah. There we go. Perfect. Just yes, yeah. I don't know why I thought that'd be a touch screen. Okay, great. It's a very short history, so it's great. So they described focal corneal fibrosis in the right eye, which is not this eye, in the left eye, which is this eye. They described glaucoma, hyphema. They said it was a non-visual eye, and there was uveitis. And they said yes to glaucoma. That's it. Great. Thank you, Gillian. All right, so here's the hemisection of the globe from that case. So there is an anterior chamber. It's a little bit narrowed. There's just kind of the lens is kind of bulging and pushing the iris leaflets forward a little bit. Our lens is cloudy, so there is a cataract. The retina is detached, so this kind of billowy membrane is retina. Looks like it's torn in areas as well. It's kind of lost its attachments. There is some hemorrhage in the eye, and then kind of just this tan to opaque red material, mostly surrounding the lens. So let's do the histology. Okay, I guess I can actually do a subgroups. Maybe. Oof. All right, so we have cornea up top, kind of holding it with my left hand, which is my shaky hand, so my apologies. So cornea looks pretty unremarkable from this view. Here's our iris leaflets, and it does look like they're perhaps adhered to the anterior lens capsule, so we have a posterior synechia. There are these areas with just a little more busy and purple, which usually indicates some sort of cellular infiltrate. So we move back and look at the lens. It doesn't look quite right. It's kind of misshapen. There's areas where there's also maybe more purple. And there's kind of just a difference in the quality of the lens fibers. Again, we can go a little closer to show that. There's indeed a little bit of hemorrhage in the eye, just a little bit. Let's move back. Here's our retina. It is indeed detached. And there are some areas where it looks torn as well. And then here's our tiny little optic nerve head. It's a bit distorted by the detached retina. Right. So our cornea, if I can focus, is on the right. As I move left, this is where we get into the posterior segment. And similarly, the cornea doesn't really have too much going on. I'll just show now. There's a little bit of peripheral vascularization, which is quite non-specific. And somewhere there is one tiny break in Desmond's membrane. Right there. It's very cute. That's the only one. Then moving back to the actual good stuff, we do indeed have a posterior synechia, so that iris is pretty broadly adhered to the anterior lens capsule. There's kind of this, it's a little busy, but there is a fibrovascular membrane. I'll go one closer. Why not? Show that. So there's kind of this loose membrane that's adhered to the posterior surface of the iris, the anterior lens capsule. It kind of extends over the ciliary body. This becomes a little bit distorted and messy, so it's a little hard to make out, but there's kind of just this broad fibrovascular membrane kind of just lining these anterior structures. So the purple, kind of the busyness, that cellular infiltrate, is within the anterior uveal tract, so a little bit in the iris. We go closer. They're lymphocytes and plasma cells, which is probably the most common inflammatory infiltrate we see in the uveal tract. And then also extends a little bit into the ciliary body. So we have an anterior uveitis. And then as we move over to the lens, which is probably the most exciting part, we'll just stop here, go a little closer. So we're at the anterior lens right now. So we have a thick anterior lens capsule, and this is the normal anatomy of the lens capsule, is thicker anteriorly. These are the cortical lens fibers here, and they are not quite right. I don't know if I have a super normal example anywhere, but normally we should see kind of eosinophilic, this kind of lamellar arrangement of the lens fibers. And here they're liquefied, th're forming these Morgagnian globules, which is a hallmark for a cataract. And then there's also a lot of cells in here too. So there's macrophages, these guys here. We have some little neutrophils. They're not super intact looking. They're kind of fragmented. It's a little hard to make out the squiggly nuclei, but they are neutrophils. And that is indicative of a lens capsule rupture somewhere. Inflammatory cells should not be able to traverse an intact lens capsule. So already seeing that, we can say 100% there is a lens capsule rupture. In this case, it's quite obvious. So we follow the lens capsule, it becomes discontinuous. We kind of pick it up here. Kind of move around too. Let's see. There we go. There's areas where the lens capsule kind of gets weird, this weird split to it. And then other areas where, yeah, it becomes kind of undulant, and then we have another discontinuity. So there's a few areas with lens capsule rupture. And if we move out to kind of the vitreous and the posterior chamber surrounding the lens, there's also an inflammatory infiltrate. So there's this exudate that's also composed mostly of neutrophils, kind of intact and fragmented neutrophils, and then some macrophages. And then just a lot of kind of nuclear debris. There's liquefied lens protein out beyond the lens capsule, just hanging out in this exudate. And then, as I mentioned, a little bit of hemorrhage. Let's see. So these findings, this intralenticular and perilenticular inflammatory infiltrate, lens capsule rupture is very, very suggestive of what we call septic implantation syndrome, which is where there's a contaminated penetrating trauma through usually the cornea into the lens capsule. It seeds bacteria into the lens that festers for some period of time. And then there's kind of this explosive inflammatory reaction you see later on. So there's lens capsule rupture, and then there's just this intralenticular and perilenticular exudate. What can be helpful to kind of send this point home is finding bacteria in the lens, which luckily, so here's our gonio slice, so just an extra slice we take of the globe just to get more views. And within the lens, fortuitously in this slice, we do have some bacteria. Hopefully I'm able to resolve it on this scope. Just these little guys here. It's a little hard to make them out, but they're cocci. They're just hanging out with these inflammatory cells. I feel like, yeah, there's a couple of cells that are also loaded up with bacteria in their cytoplasm, so they've done their work. So all in all, we can say that these findings are consistent with septic implantation syndrome. So likely this dog got into some trouble, maybe misadventure, potentially as a cat at home, a cat friend or foe. The most common, a frenemy, yes. It is a young lab, so I could see it maybe getting in a cat space. As I've alluded, like the most common cause of septic implantation syndrome, or most common traumatic event we associate with it is cat scratch injury. And as I've mentioned, I'll just show the retina really quick. It is detached, and there is evidence of retinal tear. So we have this kind of rounded edge of the retina, which helps us say that there is a true tear here, as opposed to an artifactual one. And then just looking at the retina, it's a little bit inflamed as well, kind of just scattered lymphocytes and plasma cells. And there's a little bit of outer atrophy. So this is the photoreceptors, the inner and outer segments of the photoreceptors, and they're maybe a little bit attenuated and blunted. So a little bit of atrophy likely due just to the detachment. And they just said yes to glaucoma in this case, which I would believe there's definitely reasons for it. We have those fibrovascular membranes, the posterior synechia, we have all this inflammation. But due to the retinal detachment, we can't histologically confirm glaucoma. So the optic nerve head is pretty distorted by the detached retina, so we can't see like a true cup. With retinal detachment as well in the face of glaucoma, we don't always see loss of the ganglion cell layer, which is what we look for to clue us in that there's glaucoma. So in this case, I believe there was glaucoma. We just can't confirm it. Okay. So go to my diagnoses. Here they are. Yeah, major thing is these findings are consistent with septic implantation syndrome, and then we just have a lot of kind of secondary lesions associated with that. So probably good news, good prognosis for the dog in the other eye, but yeah, kind of a bummer. Hopefully it stays out of the cat space going forward.
Goggles.
Goggles, yeah, get some goggles for that other eye. Okay, if there are no questions, I can move on to my next one, which is a more recent one. So this is the globe from an 11-year-old male castrated, also Labrador retriever, a lab mix. We have these beautiful images that were provided by the clinician. We only got one of these eyes, so we received the left globe, this one here. And they gave us a thorough history, which I will summarize a little bit. So the patient presented for pain associated with the left eye. Glaucoma was diagnosed at that time, and it was noted that the iris was hyperpigmented with multifocal iris thickenings, as well as posterior synechia. They provide us with some differentials, which are great differentials, but I will withhold them. And they were worried about the prognosis for the remaining eye, which is the right eye. That's the one that's still within the dog's face. They had mentioned that the right eye had scleral pigment and multifocal iris thickening with a deeply pigmented iris as well on that side. So they were thinking a similar process was happening in both eyes and worried about the prognosis for this one, wondering if it would also develop glaucoma, probably. Okay, I do not have a gross image from this eye, but grossly we had described the left eye as buphthalmic. We noted that there was scleral pigment, mostly at the ventral limbus, which we can't quite see here, as well as the dorsotemporal equatorial sclera. And we said that the iris was pigmented and it seemed a little bit thickened circumferentially. All right. It's kind of misshapen, so it's not going to sit very well. Focus. There we go. So this one's a little bit cleaner compared to the other eyes, way less inflammation. There's no inflammation. So we have our cornea up top, looks unremarkable from this view. We have our uveal tract, which already from this subgross view looks quite pigmented. All the way back here, even the choroid looks pretty heavily pigmented. And even from this low power view, the iris leaflets just look kind of funny. They're a little bit pudgy looking, and this one's kind of a little bit misshapen. Lens isn't particularly exciting from this view, and then we also do have evidence of chronic glaucoma, so we can already see from here that there is a cupped optic nerve head. So we're able to corroborate glaucoma in this case. We can also see from this view that there is a little bit of pigment in the peripapillary connective tissue. As well, over here on this side, I imagine this is probably the dorsotemporal sclera that we described grossly. There's also some pigment out in the sclera, maybe episcleral connective tissue. So similar orientation, cornea, oh my goodness. Cornea is on the right, posterior segment will be on the left. And cornea, there really isn't too much going on here. So there isn't too much to say about it. Maybe there's, yeah, a little tiny bit of peripheral vascularization. Main event is going to be in our uveal tract. So as I mentioned, it's heavily pigmented pretty much throughout the entire uveal tract. And we have this distortion of mostly the iris where it's just thicker, and then maybe a little bit of the ciliary body too. We're kind of just getting this obscurement of the normal architecture. I'm just gonna go straight down and look at it. Oh, I don't know if the camera's gonna love this. Oh God. Bear with me. The camera's maybe not super happy about the pigment. You might have to believe me on some of the things I say. So this population that's causing this distortion of the uveal tract is pretty homogeneous. It's kind of just these round cells. They vary in size a little bit, and they're just loaded with these kind of coarse dark brown granules, which is consistent with melanin pigment. Oftentimes, those granules kind of obscure the nuclei. We really can't make them out in a lot of these. Every so often, there's one that kind of is able to clear through the fog a little bit. And they're pretty bland. They're just round to oval. They have pretty fine chromatin. We can maybe make out one nucleolus. And this is a pretty consistent population throughout. We move around away from that iris to show it. So again, just kind of similar cells. They're quite bland. And they're also out here in the peripapillary tissue. And then also sneaking into the sclera. So maybe a little bit of the episcleral tissue / conge, which I believe we could definitely see grossly on an intact globe. And then in this particular one, this iris leaflet is quite distorted. There's kind of this funny little anterior synechia. So here's desmase where it ends right here. It's kind of weirdly adhered and misshapen. So when we have, at the very least, we have a heavily pigmented uvea. When we start to see this distortion, kind of expansion of the uveal tract, that then leads us to wonder, could this be either a melanocytic neoplasm, so a melanocytoma, or a malignant melanoma, or could it be uveal melanosis, which is a non-neoplastic proliferation of melanin-laden cells? So in this case, this is most consistent with uveal melanosis. A melanocytoma, I guess, would be our other more logical differential. With a melanoma, I'd expect to see an elevated mitotic rate. There would be kind of a slightly different look. A melanocytoma, though, we would expect to see likely more of like a focal mass effect, like an expansive mass effect. And on top of that, we tend to see what we call a double population of cells. So in addition to these round cells, we oftentimes will see this concurrent kind of spindle cell population. So in this case, given that we just have this very mild distortion, it's kind of a diffuse distribution. We also have this pigment that's spreading out into the adjacent soft tissues. Again, most consistent with melanosis, which was the clinician's top concern for this case. So I guess I don't have too much else to say about this one, so I'm going to move over to the diagnoses while I talk. Oh yeah, I guess I could, sorry, I didn't really show the synechia very well. I guess I have time to show it. We're kind of speeding through cases today. Sorry, we're fast talkers here.
I got some cool.
Oh, good. Okay. So this little synechia here, we said was most consistent with iris endothelialization. So you can kind of follow, here's the corneal endothelium. You can kind of follow it up over this distorted iris that's adhered to the posterior cornea, which this isn't super specific for anything. Oftentimes we'll see if there's some sort of trauma to like desmase, the corneal endothelium, it gets a little bit frisky and it'll kind of just spread over the iris and it can obstruct the iridocorneal angle and contribute to glaucoma in this case. All right, now I will actually go to our diagnoses. Those are the main things. So yeah, we said this case was most consistent with uveal melanosis. This is a lab, yeah, which there's a couple of breeds that are predisposed to this condition or overrepresented. Kind of the poster child for uveal melanosis is the anterior, which typically will present in a bilateral manner. So if we diagnose in one eye, it's most likely the other eye will also have it in the anterior. It has also been reported or overrepresented in Labrador retrievers, boxers, and French bulldogs. And in those breeds, it's not necessarily bilateral. But in this particular case, given the lesions that they described in the other eye and kind of what we can see in this right eye, it's quite possible that this is a bilaterally, or this condition is bilateral in this patient. So it's possible that this other eye is going to develop glaucoma at some point. And as I just said, uveal melanosis is often associated with glaucoma at some time point due to that distortion of the iris. Also, you can see quite a bit of pigment dispersion, so pigment that kind of goes down into the drainage angle and, for lack of a better word, gums up the works, which is most likely what happened in this particular case. So definitely the clinician want to keep a close eye on that other eye for glaucoma arising.
Did you mention other breeds?
I did. I said Labrador, French Bulldog,
Okay,
boxer.
sorry.
No worries.
I zoned out at the inopportune moment.
You know, I was kind of rambling, so. And I think those are kind of my main points for this case. If there are no other questions, I can pass it on to Gillian.
Just a point about the use of melanosis in cases where you have a cellular proliferation, because by convention, if you have a cellular proliferation of melanocytes, it's not melanosis. Melanosis is the pigment deposition, so you're depositing pigment in receptive cells like keratinocytes or something, right? And so the presence of a cellular population is, even if it's an infiltrative mass rather than a diffuse expansile mass or an invasive mass, suggests that this isn't simple. The term melanosis would be a misnomer, right? So if we have melanosis in the sheep's meninges, right, is that a mass effect? No, it's never a mass effect. And one of the gross features that we use for teaching students to differentiate between melanosis and melanocytoma, melanoma, is whether there's a mass there or not. Is it a macule or is it a papule? Once you go from being a macule to being a mass, you have a cellular proliferation. And so that doesn't fit with this paradigm that you guys present in the eyes. I don't know how that translates into like more broadly, like people and other.
I was gonna say, haven't we adapted this from human melanosis?
That's what I
So
thought. But
I'm not sure actually
could be misspeaking.
the history of this term. Interestingly, with the nevus of Oda cases, it's called oculodermal melanocytosis.
right,
But for
and that's what.
And
I
that's a
expect this to
proliferation
be.
of melanocytes. So yeah,
uveal melanosis, isn't it like kind of up for debate, the exact cell proliferating?
it is melanocytes.
It's melanocytes. Okay.
Yeah.
For some reason, I thought melanophages were also okay.
There, no doubt, there are
Okay,
melanophages
okay.
in
That's what I'm
every
thinking.
single case of uveal melanosis,
Mhm.
but the most of the cells they have proven
That is a
that they are
melanocytic.
melanocytic. Yeah.
what it's worth, recently we had a case submission where in the history the clinician called it melanocytosis. So
Mhm.
maybe the term is slowly catching on.
Yeah.
That's interesting because I don't recall ever hearing clinicians mention
Almost
that.
never. We had one case recently though, where someone sent in their history, they called it ocular melanocytosis.
Yeah, I see.
Yeah.
Yeah, I think it's published most commonly as ocular melanosis specifically, and
Yeah.
we call it uveal melanosis because I think that's more specific.
Contactful, it's both names.
I suppose and I've been putting both of them like
Mhm.
to the same reason. Maybe like we could speed that on by using the term melanocytosis. I don't know.
It's just the peculiar inconsistency that
Yeah.
goes back to like fundamentals of why we call some things
Mm-hmm.
And
melanosis versus a mass.
Mm-hmm.
It could also come back to also that brings up the different terminology used clinically, especially in the eye,
yeah,
compared to what we use in like histopathology. So maybe it originates with the clinicians and the like
Because they're just seeing like
pathologically,
a
they
heavily
would call it
pigmented
something else.
eye as opposed to like a discrete mass.
Yeah.
I could see that.
Yeah.
It does, yeah.
Thanks.
Yeah.
Rail the conversation later.
It's okay, we have time today, so it's good.
Good thought too, for trainees, to think about why we use the language that we use. Yeah.
And why we talk so much about language and pathology.
Yeah, so then when someone corrects us because it's changed, we'll know why.
Someone asked in the chat, is there a threshold of pigmentation that delineates a heavily pigmented eye in melanosis? Ha!
I think someone just start to see distortion.
I wish, yeah, when it starts to distort, i.e. expand the uvea, is when we would bump it up from a heavily pigmented uvea up to melanosis. And I would say that sometimes I will call it a heavily pigmented uvea and then list a differential of uveal melanosis and caution the clinician that if it's uveal melanosis, it could be bilateral. So yeah, I don't know. Did that answer your question? Hopefully it did. Okay. Let's move on to my cases. Okay. This is the eye of a dog. Do you want to? Okay. This is a dog. It is a 4-year-old miniature poodle. Toy poodle, excuse me, toy poodle. With a very brief history. They say chronic glaucoma and post-CBA, which stands for ciliary body ablation, and then possible rupture. I'm not sure exactly what they were referring to with the rupture. We did not perceive a corneal defect, so I think they were referring to this proliferation of tissue at the limbal sclera there. So CBA, ciliary body ablation, they did not tell us what they used, but typically we assume that they have used gentamicin. And so they'll inject that into the vitreal space, and that is essentially quite toxic to various parts of the eye, and it will kill off or cause necrosis of the ciliary body epithelium. And remember that the ciliary body epithelium is what is responsible for producing aqueous humor. And so when you have a decrease in aqueous humor production, then you have a decrease in IOP. So essentially, it is a very simple way of treating glaucoma. And it's very cheap. So owners will often opt for that rather than other treatments for glaucoma. Some people have started using cidofovir as well. So similar process, you inject it in the vitreous and it is toxic to the ciliary body epithelium and will lead to decreased aqueous humor production. For sure, gentamicin is also quite toxic to the retina, so it will often lead to retinal necrosis as well. But at the point that you've chosen to treat an eye with this, essentially you're trying to prevent enucleation and to create a comfortable eye. So it is already blind and you're just wanting to prevent a surgical procedure. Oftentimes, people will do it with relatively simple glaucoma where there's not a whole lot else going on in the eye, and or when the dog has significant comorbidities, and so anesthesia is a problem. So at any rate, the duration of problem for this dog was chronic, they say chronic, over 5 months duration. So here's the eye, and we reported that it was quite ophthalmic, and that there were these tan masses in throughout the anterior uvea at both sides of the eye, and then also that extended through the limbal sclera at this side and into the like sort of posterior orbital tissue as well. So there is also quite a bit of hemorrhage in the eye. You can see it's solid hemorrhage up here in the anterior chamber, and then in the posterior chamber and vitreal space as well, and maybe some in the subretinal space. This is the detached retina, at least on that side. There's also quite a cataract. And it looks like there is hemorrhage mingling with the cortex of the lens, so chances are there was also lens capsule rupture. I will say that a decent number of globes that come to us after the history, with a history of ciliary body ablation, have lens capsule rupture. And I don't think gentamicin is directly toxic to the lens capsule that I'm aware of. I mean, the lens capsule is sort of an inert substance at that point. It's just collagen. However, so I often sort of assume that they have hit the lens when they injected the gentamicin into the vitreous. But anyway, so looks like we have lens capsule rupture in this globe as well. Okay. So there's the cornea. There's our hemorrhage in the anterior chamber. As we move more posteriorly, here's the iris on that side of the eye. You can see that it is expanded and slightly purplish. It does extend back into the ciliary body. And on this side, similar story. We have iris here, ciliary body here. They are more affected. In this case, that cell population also extends into the peripheral cornea, into and through the limbal sclera, and it forms this mass in the episclera. And it kind of extends back along the sclera here. And this is actually the gland of the third eyelid. So we had noted that the third eyelid, was posteriorly displaced grossly. So here's the leading edge of the third eyelid. So the mass was kind of bulging forward and sort of causing a posterior dislocation of the third eyelid. Okay, so whenever we see a increased purpleness to a tissue, we always assume there's some sort of infiltrate. And in this case, we have quite a bit of expansion of the tissue. So from low mag, we can see that the responsible cells are sort of forming these well, not interesting, but vague bundles, streams, lobules. You can see they're kind of streamy over here. Whenever we see streams and bundles, we start to think about a mesenchymal cell population. Mesenchymal cells are often spindle-shaped. And so that is the population that we have here, is a population of spindle cells, kind of haphazardly arranged in bundles and streams. They have variably distinct cell borders, and they have eosinophilic to amphiphilic cytoplasm and oval nuclei that have kind of finely clumped chromatin with a single variably prominent nucleolus. I'm gonna. What's that?
Your mouse.
Oh, thank you. Oh, look at that. Okay, cool. Thank you for that. So as we look around, in some areas, here's a nice area. Here's a good mitotic figure. I can zoom in, look at him. Woo! Thanks. I forgot. I forgot we're allowed to do that. So we've got quite a mitotic rate around. So we've got a fairly malignant looking spindle cell population. It is entirely within and expanding the uveal tract, the uveal stroma. I looked around and I'm trying to remember where it may have been, but I don't remember. I think on a very rare occasion, some of these cells had very lightly pigmented cytoplasm. I'm not gonna be able to find it now, but here's another area where they're not quite, or they're much plumper, less kind of spindle shaped. So this these features of prominent nucleoli and after years of staring at malignant melanocytes, I'm pretty sure this is a malignant melanoma that's poorly pigmented or amelanotic you could use. Oops. So those are the features of the tumor that I believe are relevant. Let's just look at the rest of the eye now real quick. I think the cornea was pretty boring. Right here we can see, here's the edge of the lens. And you can see that discontinuous lens capsule that's kind of coiled there or curled. And then we have some cells that are kind of butting up against it. I think those are actually neoplastic cells in this case. But we also, at this point, we're sort of within the lens capsule. And you can see all that hemorrhage that's mingling with the degenerate lens fibers. So we have true lens capsule rupture here. As I said, I kind of am suspicious that this probably happened when the gentamicin was injected. I also mentioned that gentamicin is toxic to the retina, and what it often causes is these little rosette kind of structures to form in the outer nuclear layer. It's a common finding. I don't know the exact pathogenesis, but anyway. So that's common with gentamicin as well. This globe also had an inflammatory infiltrate in the choroid that consisted of lymphocytes and plasma cells. I don't know the exact cause of this. It may have been pre-existing prior to the gentamicin. It could be related to the lens capsule rupture, so it kind of developed after what I assume was the injection-induced lens capsule rupture. So, and then I mentioned that the, let's see here. We didn't actually sample the optic nerve head in this case. But I did mention that the retina was detached on that side of the globe. And here's detached retina. This is the choroid. And to convince yourself that it's detached, you can look for a few different things, including hypertrophy of the retinal pigmented epithelium and or material in the subretinal space. And I can't remember what the RPE looked like. Sometimes, well, not sometimes, but eventually the RPE will actually sort of give up and stop being hypertrophied. And I think that's what's happened here. So they're no longer the little tombstone shape. They've just completely given up the ghost. Okay, anyway. So we have a globe that was diagnosed with chronic glaucoma and was injected with presumed gentamicin or cidofovir to decrease the production of aqueous humor. And we have this really extensive malignant tumor. So which I believe is a malignant melanoma. So we do not believe that gentamicin causes tumors to form. However, we do believe that if you inject gentamicin into an eye that has a pre-existing tumor, it can make that tumor more aggressive, more malignant. We don't know the pathogenesis. I think it'd be a really cool PhD to figure that out. Maybe someone knows out there why gentamicin would do that. But at any rate, so I can't really propose a cause for the original cause of glaucoma in this case because of how extensive the tumor is. But poodles are very well known for their goniodystrogenic globes, so it could have been goniodystogenesis. I'm not really sure. So in this case, I believe that there was a pre-existing tumor that was missed or not diagnosed or whatever, and that they decided to inject with gentamicin. Maybe they knew there was a tumor and they decided to inject with gentamicin anyway. That is ill-advised as far as Coplow is concerned. Then yeah, so it angrified a tumor that then became quite extensive. Generally speaking, malignant melanomas in dog eyes have a very low metastatic rate. It's like 2 to 5% or something. So they're sort of malignant looking histologically, but generally speaking, they still have a relatively benign biologic behavior. They don't typically metastasize. I don't know how that relates to angrified gentamicin angrified tumor. So, and this was a relatively young dog. I feel like this was a 4-year-old toy poodle. So, I don't know. Hopefully, it never goes on to develop any metastasis from this. Any questions? We're good. Okay, I've got time for my last case. Cool. All right, next up is a 5-year-old domestic short-haired cat, spayed female. Once again, got very brief history here. They say retinal detachment with secondary glaucoma, and in parentheses, they said previous FIP. So I thought that was pretty interesting.
Magic cure.
Yeah, I got the magic cure, I guess. So generally speaking with FIP, we expect a high protein intraocular exudate. And what that means, grossly speaking, is that the vitreous is typically a solid, cloudy gel. And then typically, if any expansion of the uveal tract, it would be very minimal. And essentially, the expansion that we see with FIP is inflammatory rather than neoplastic. And usually, inflammatory infiltrate in the uvea of a cat will cause like sort of barely perceptible thickening of the iris and ciliary body, grossly speaking. What we have in this eye is a little bit different, however. So we have thickening of the iris and the ciliary body that is pretty prominent. It is off-white, so that doesn't really tell us much about the cell population at this magnification. The lens is relatively boring in this case. And then the vitreous is actually fairly clear. There is material in the vitreous, but most of the vitreous is clear. And then what we also have is the retina is detached here and thickened. So it's obviously detached on this side. It's not as obvious on this side. In fact, it might not be detached at all on this side, but it's quite thick over here. And we also have some sort of exudate or cells that are sort of adhering to the uveal surface, the ciliary body surface on both sides of the eye. So this is not looking like the typical FIP eye. Let's see what's going on. All right. So we'll just stop here. Here's the cornea on the left. Here's the iris. Here's the lens. And we're heading back. Here's ciliary body, heading back to peripheral retina here. So what we have is this expansion of the iris, which is common and true on the other side as well. Over here, let's go back over here to this side. So we have areas where it's more purple and areas where it's more pink. And I will tell you right now, those areas of pink are areas of necrosis. So this is, so necrosis in an inflammatory cell population does happen, but this sort of regional, really prominent necrosis is much more typical in a neoplastic cell population, at least in the eye. So we're looking at a tumor here. And when we look at what was going on the other side, and this was the side where the retina was obviously detached, the retina is also quite purple, and it doesn't really display much of its normal layering. So there's something infiltrating the retina on this side as well. And the choroid on this side is a little bit busy. It's not quite as purple as the retina is. And then we've got some cells that are sort of adhering to the ciliary body surface here. So let's go higher mag and check it out. So once again, we have cornea. Here's our iris, ciliary body on this side. So let's look at this population at higher mag. So one of the prominent features of this necrosis, at least in this exact area, is that there's survival of cells around the blood vessels, which is not uncommon in tumors. This usually implies that the rest of the cells are undergoing hypoxic necrosis, or ischemic necrosis, rather. And that usually implies a fairly fast-growing tumor. They said duration of problem was 3 months in this case. They didn't tell me when the previous FIP was, or whether it was treated with anything. Presumably it was treated with the newfangled drug, but we don't know. I don't know. So what we have here is a population of round cells. They have fairly discrete, they're fairly discrete, so prominent or perceptible cell borders. I've forgotten the word at the moment. They have relatively large, relatively small amounts of cytoplasm that's kind of amphiphilic or eosinophilic when you can find it. And then large round nuclei with coarsely clumped chromatin and single prominent nuclei. You can see a great big one here. In this population, we also see a fairly brisk mitotic rate. So here's one here, here's one here. And then we also occasionally see little shrunken nuclei. So we've got some apoptosis probably going on as well. So this morphology, also the cells are not forming any structures. They're just arranged in sheets. And so this is very typical of a round cell neoplasm. And my bias is quite high for lymphoma in this case. Let's go over and take a look at what's going on in that retina on the other side. It is in the ciliary body. The neoplastic cells are also mingling with the ciliary body epithelium. Sorry, we took a detour there. With the retina. Okay, there we go. There's our retina. So the retina is detached and it is entirely effaced by a similar neoplastic cell population. So round cells with similar morphology to what we saw in the iris on the other side. And then when we move into the choroid, we have, once again, a similar population. So we have a round cell neoplasm that is circumferentially affecting the globe, the uvea. Whenever we see this, and as I said, my bias is pretty high for this being lymphoma. So whenever we see circumferential involvement of a tumor, it makes us think of what we uniformly used to think of as post-trauma tumors. However, this entity, this lymphoma, is being rebranded chronic uveitis-associated lymphoma. So not necessarily associated with trauma. This is probably associated with chronic uveal inflammation. Remember, this cat had a history of FIP, so I would sort of conjecture that this globe probably had a chronic lymphoplasmacytic uveitis that then the lymphocytes of which eventually underwent neoplastic transformation and turned into a lymphoma population. So in cats, these post-traumatic, what we used to call post-traumatic lymphomas, this chronic uveitis-associated lymphoma, are most often B-cell lymphomas, but they can also be T-cell lymphomas. And we consider these to be presumed solitary ocular lymphoma. So it is initiated in the eye. They can become systemic from the eye, period. So sorry, I'm not sure what I was going to say about that statement. All right, cool. Not cool for the cat, but it was, yeah, CUAL. So never mind, morphs. So feline chronic uveitis-associated lymphoma, or CUAL. I guess the margins were dirty somewhere. I can't remember where they were dirty, but anyway, so that's all I have to say. Were there any questions about this? Did I say everything that I needed to say about it?
Yeah,
Okay, cool.
I think one thing that's worth pointing out also is that with the new antiviral therapies for FIP, we don't know what the consequences of that therapy are gonna be on inflammatory responses, either residual to it. And there aren't any studies that I know of right now that are ongoing to look at the consequences of treating and curing. We just have multiple studies looking at whether we can reduce the incidence of disease as we currently recognize it. And so I'm suspicious that as you guys are out of practice, you're gonna recognize things that we're gonna be tying back to previous FIP, but we don't know what those are yet. Just keep it on your radar.
There's one question from the chat. Is there a known rate of recurrence with dirty margins in a case like CUAL?
No, we do not know. That's a good question, and I can't remember in this case. So in this case, they submitted it as a well-trimmed globe, which means that they had already removed some of the extraocular tissue, probably the eyelids, the conj, etc. So it's very possible that the margins are actually not dirty. Obviously, we can't really comment on that much, but that's something to take into account in this case. So, any other questions? Cool. All right. Thanks very much.